What I'm going to try and talk about for the next little while is the truth about the Canadian healthcare system and the Patient Protection and Affordable Care Act. But first you have to know a little about me. You heard a little about me. One of the important things to understand in offering the nostrum of the America's Affordable Health Choices Act is that Obama and his minions are like the king in Through the Looking Glass, when the king said, "I didn't say there was nothing better. I said there was nothing like it." And I think slowly Americans are catching on to the con, but it's a challenging con because the way the words come out, it sounds very enticing. Me, I was born, raised, and bred Canadian. I grew up in Toronto. It was a great city to grow up in. It was sort of a city that was a little bit backwards when I was born and sort of grew up in when I was young. And then it sort of evolved into a cosmopolitan city. And like all great Canadian things, it has slowly become second-rate. For a lot of reasons, predominantly because of social engineering. But I did receive my medical training in Canada. I did practice in Canada. I did receive my specialty certifications in Canada. As a former Canadian physician forced to practice socialized healthcare, however, I've seen this all before. I've also personally seen it at the Veterans Administration and in the Medicare system and in the Medicaid system that we have here. Bureaucrats do not care one iota about you or your health. A fundamental tenet you have to walk away with.
Keep going.
Are we good?
Yeah.
Okay. They simply lie and make stuff up to shove healthcare restrictions and denials down the throat of a captive group in the name of efficiency and cost control.
That's better.
Oh, perfect.
Good.
And blame their constituents for the harm that they create. The Canadian socialized healthcare system began as an idea back in the 1940s. The drive for universal access began in 1946. This was not something that came up overnight. This is something that had to work its way through the system. The concept was to create universal access. What they didn't realize is that eventually they'd create universal access to misery. The Canada Healthcare Act, which finally solidified the Canadian healthcare socialized system, came into full being in 1984. Started in 46 and eventually went through. I was part of that 1980s because that's when I finished my training and I started practice in Canada, in Toronto, and Ontario was the last bastion to not acquiesce fully to the Canadian Healthcare Act. And there were things that Canadian doctors were allowed to do that weren't part of this universal healthcare system. But in 1984, all of that became outlawed. Indeed, Canadian doctors, particularly in Toronto, went on a doctor's strike, if you can imagine such a thing. They actually left their offices all in white coats and marched up to the local parliament building, the provincial parliament buildings, and protested. That lasted a couple of days because, in the end, there was no acquiescence by the government to change anything. The Canadian Healthcare Act is based on 5 principles. The first principle it's based on is that it's going to be publicly administered, so that it's run by a public authority and that it's to be non-profit. Basically, when you reinterpret all of that, that becomes one thing: single payer. Nobody else can do that. The second principle it was prefaced on is comprehensiveness, meaning that it will cover all insured health services provided by hospitals, medical practitioners, and dentists. The third premise is that it be universal, or universality. In other words, all persons are covered the same. The ultimate collectivist concept. The fourth concept was portability, meaning that you can use your health insurance no matter what province you're in. And for those of you who aren't familiar with a province, it's like a state, except in Canada, they're big. So we have basically 10 provinces and a few territories, as opposed to 50 states. Finally, the fifth tenet was that healthcare be accessible, or accessibility. Now, I will quote and paraphrase what they mean by that. What they're talking about is reasonable access to insured services on uniform terms and conditions, unprecluded, unimpeded, either directly or indirectly, by charges such as user charges or extra billing or balance billing, or other means such as age, health status, or financial considerations. Sounds really fantastic. It really does. I mean, you could sell people on this. It sounds like, this is great. We're going to get everything, and it's going to be just a Shangri-La. Let's talk about reality. In reality, it is not really about universality. Physicians don't set their rates, the government does. And it doesn't do it through any particular formula that's based upon need. It's done through a negotiation between the various medical associations and the government, depending on its budget. So it's done by parties that are removed from actually the doctor's office. They're all calculated, and that's it. You can't charge anything else. You can't receive anything else. It also covers some dental services. What doesn't it cover? Now, this is something that they don't really talk about. The Canadian healthcare system doesn't cover a lot of stuff, except variably to certain groups, such as seniors and children, and some groups that are on social assistance programs. Prescription drugs aren't covered. Now, that's very interesting because you would think that everything would be covered. Well, prescription drugs aren't covered, and that comprises 10% of healthcare costs. Well, that's a good way to not include those costs in your budget by simply saying, we're not paying for it, you are. What does that mean? Well, there are consequences to that I will talk about. It doesn't cover medical equipment and appliances. Like what? Wheelchairs. You've all seen the wheelchair commercials. There's tons of them on television all the time. It costs me nothing. Absolutely nothing. That's what the guy says on the TV commercial. Why does he say that? Because Medicare pays for this. Medicare will pay for your wheelchair. And in Canada, it does not. You got to pay for it. Now, the cool thing about it is that here, because Medicare pays for it and Medicare sets a certain fee, then the wheelchair only costs so much. In Canada, because they don't pay for it and because they have a captive audience, when you need a wheelchair, you will pay like one of those motorized scooters. You can buy that here for $600-700. In Canada, even though you have to pay for it, that same scooter is going to cost you $2,500. All right? And that's not the exchange rate between Canadian and American. In fact, the Canadian dollar is worth more. That's how great our economy is doing. Which is really scary to me. The Canadian healthcare system doesn't cover allied health professionals. What do I mean by allied health professionals? Non-hospital-based physical therapy. You want physical therapy outside of the hospital? Got to pay for it. You want to see a podiatrist? Got to pay for it. You want to see a chiropractor? Not covered. You need independent living help at home? Not covered. Indeed, the fallacy of comprehensiveness is profound. Only about 70% of healthcare costs are covered by the Canadian government. So really, it doesn't cover everything that they're trying to get you to believe that it does, and the con that they're selling you that will just cover everything. It doesn't cover everything because it can't. And it knows that it can't. Interestingly, in the United States, a little tidbit for you to know is that government currently pays for 45% of all healthcare costs through its various programs, like Medicare, Medicaid, Veterans, and the Children's Health Insurance Program, which is known as SHIP. So the American system is getting there. 45% of your healthcare costs is getting to a tipping point where almost half of healthcare is being paid for by government here already. In Canada, it's 70%. Just remember that. So we're not too far away already, and that's before Obamacare. The fallacy of access. It was one of the great things that was offered in the Canadian healthcare system, that you'll be able to get to a doctor whenever, wherever you need it. However, in Canada, you need a primary care physician to get into the system. That's your gatekeeper. Without a primary care physician, you can't access anything except through the emergency room. Big problem is that rationing of physicians is causing a shortage and a restriction upon where physicians can practice. In other words, There aren't as many family physicians as needed to service the population because the government won't allow you to open up shop and because the government won't pay for someone to open up shop because government pays your services. Now it is fee for service. You bill for the, just like here, you know, you see a patient on a visit, you bill the visit, but you bill the government. That's the only payer. And so that's it. You just have this back and forth. It's sort of the one payer system. So, not enough primary care physicians. Government decides where you can actually practice. If I wanted to open up a practice somewhere and say, I'm ready to open up a shop, I'll get an office, I'll rent the space out, I can't do that. Government decides where you can practice. It determines the ratios of what kind of doctors can open up in a geographic area and how many of them can be there. And you can't get a hospital appointment unless the government allows you to practice. It's a very tightly controlled system. And so the whole system can't be expanded because government dictates who can practice where and what. In addition, hospitals can't just open anywhere they want because they're totally dependent upon government for their fees and for their budgets. And because of that, hospitals aren't opening up left, right, and center based on need. To the contrary, hospitals, as you saw, and that's a truth, hospitals close units. They close wards, they close beds, they restrict complete access to services based solely upon costs, the budget. Is there enough money to actually fund running the unit? Is there enough money to fund running the floor? If not, it's closed. And then they calculate how long they're going to close it for until they make up the budget. Rationing is not only common to physicians and hospital beds and hospital wings and surgical suites, but also emergency rooms. Even though you heard a terrible story about someone demanding emergency services, emergency rooms close down. And it's not like you have walk-ins like we do here if you have sort of a semi-emergency where you might want to just take care of something without, utilizing the intensive services of an emergency room. No. The only place you can get emergency services are emergency rooms in hospitals, and they may or may not be open. If they're open, the likelihood of you being seen in a timely way is unfortunately super small because people stack up. There aren't enough people to see them, and there aren't enough wards that are open, so you can't move people from the emergency room to a hospital bed because there are no hospital beds. So it's like an airport when it gets really busy. They just stack up the gurneys, and people are just waiting and waiting, and they actually do die while waiting. That is a truth. Technology is also limited in its access, as you heard, and that's also a truth. CAT scans, MRIs, PET scanners. Again, government is the one who funds these things. If government funds these things, then it's government who decides how many you will have, and when they will be open, when they will be closed, how it will be staffed. And they are all restricted. The average time that it would take to get a CAT scan, maybe if you're lucky and you have a doctor who will order one, because your primary care physician will never order one. If you need a CAT scan for some reason, like you have something going on inside that you're complaining about, you'll go to the doctor who's the primary care doctor who'll say, you need to see the inside specialist. And then you'll have to wait. But the waiting time for the inside specialist will be 8 to 16 weeks. And then you'll have to wait another 4 to 8 weeks if the inside specialist decides to send you there, but it's not likely because the mentality is one of, let's do a few tests before then. So by the time you actually get the procedure you needed, you can easily wait 6 to 12 months for a simple CAT scan or an MRI. If you get one. Doesn't mean you will. Same with therapy. Radiotherapy is similarly restricted in its access. Infusion therapy, we have a wonderful medical age now where we have these incredible biologic treatments. In my specialty of rheumatology, we've had this incredible explosion of new therapeutic agents that are done by infusions and injections. Well, infusions will require a hospital in Canada, but you can't get into the infusion centers because the hospital won't have the staffing or the services available, let alone the fact that they probably won't allow you to get the drug. Crippling diseases still exist in Canada, even though they shouldn't. Indeed, the Supreme Court of Canada in June 2005, and the doctor was up there, Dr. Chaoui, Dr. Jacques Chaoui, who actually took on the system in the province of Quebec, French-Canadian, sued the province of Quebec, and the Supreme Court of Canada in Quebec decided